Our next panel discussion is going to focus on compensation arrangements for clinicians and the challenge associated with the fact that our reimbursement mechanisms are in transition from basically a piecemeal pay-for-volume mechanism to a payment mechanism that is designed to reflect quality and outcomes and conservative cost performance and so forth. We have with us this afternoon Joe Levitch. I had the opportunity to meet Joe last night, and we had a pretty freewheeling conversation as two management consultants might. Joe is a principal with Sullivan, Cotter, and Associates, which is a human resources consulting firm working in the healthcare industry. Joe has been a human resources and compensation management consultant in the healthcare industry for 35 years. And I said to Joe last night, in consulting years, that's 100. And he didn't dispute it. His clients include hospitals, health systems, academic medical centers, physician group practices, and managed care organizations. And Joe, I'll bet that we have a lot of academic medical center clients in common. Joe is an MIT graduate and will moderate a panel discussion focused on physician compensation. And as before, I'm going to ask Joe to introduce the members of his panel and try and allocate enough time to answer all of our questions related to clinician compensation. Thank you. Please welcome Joe.
Thank you. I'm actually here in the hopes that I will learn something from the audience that I can take back and use in my practice. Thanks very much for the introduction. I'm delighted to be here. As you can see, I've made a career for 35 human years, 100 consulting years, in working with healthcare organizations on issues of both executive and physician compensation. And a lot of that is concentrated on helping identify the right performance metrics that can be used in incentive structures, both organizational incentives for executives and members of the leadership team, as well as provider incentives for individual physicians, groups, and teams of physicians who are working to deliver care. And again, in terms of background, what we're all looking at is an industry that is going through, we say here, accelerating change. I think it's interesting. Our practice as a firm spans the US, and we see an incredibly wide range and variety of practices from some markets where there is little or no quality-based care, value-based care, to other markets where the prevalence is up in the 30 to 50% range. So a significant variation in practice, market practice, an incredible amount of uncertainty on the part of systems and medical groups about what is going to happen, when is it going to happen, and how do we respond to it. The topic for today was originally defined as compensation, but I think we have to look at this a little bit more broadly. We really have to look at it from the perspective of performance, because we can't decide how we're going to compensate people, how we're going to reward people, until we first of all define what it is we want them to achieve, and second of all, figure out how we're going to measure their performance relative to those goals. Before I bring the panel down, I want to share just a couple of pieces of information. This is MIT. I am an MIT graduate, so I had to at least find some data that I could share with you, so you really will believe that I went to school here back when I had hair. The data that you see here is data that's drawn from a survey that our firm does. You can see in the footnote about 480 healthcare organizations covering the pay practices of over 100,000 physicians. We would say that the most typical compensation model that's being used is a three-part model with a base salary combined with a productivity incentive combined with what I refer to here as a performance-based incentive. Some of the statistics that come out of the survey, you can see that about over two-thirds of the respondents still pay providers or currently pay providers based on productivity, typically individual productivity, and typically measured by work relative value units. And those compensation programs account for pretty close to 60% of total compensation. So it is a fee-for-service world, so to speak, when we look at compensation practices. My primary care physician sold his practice about 5 years ago to a large health system. And on my first visit, he knows what I do, by the way. On my first visit when I went to see him after he had become part of this health system, we were talking about life as an employed physician, and he said, they've got me working on commission. I get paid X dollars for every work RVU I generate. And I thought that was an interesting characteristic. We are seeing a move in the organizations we work with towards the introduction of performance-based incentives. One of the interesting things that you will see is there's no consistency in terminology in this category. We would say that the concept of value-based compensation, which everyone is trying to achieve, really represents any form of pay that's not productivity-based. You can see from the survey results that about half of the organizations are using some form of performance-based incentive other than or in addition to productivity. One of the things that I find very interesting is that they account for a relatively modest percentage of pay, 5 to 7% of the total pay of physicians. And if you look at the details, what you will see, and this goes back to a study we did about 2 years ago, if you look across a specialty, in any given specialty, you would find as many as 20 or 30 or even 40 different performance metrics used when you look at the collective experience of a large group of organizations. No single metric typically has a prevalence of more than 5 to 10% of those organizations. Basically, the message from that is nobody has figured out what to do. Everyone is struggling, trying to figure out how to make these performance-based incentives work. As we look at some of the challenges, one of the most important and most critical is measurement. What are we going to measure? What types of metrics are we going to use? And do we have the ability to report and communicate information, relative performance information, in a timely manner? Again, in terms of one of the things that you see going on in the market now, you can look at a health system or look at a physician group. If they participate in 5 different health plans, they're probably getting 5 different messages about the quality metrics on which that health plan is going to provide variable reimbursement to them. So if you're a doctor, if you're a provider in this system, what do you really concentrate on? And how do you figure out what it is that you are supposed to be working to achieve? So the whole issue of performance measurement, and that's really where I want to start things off. Change management, system design, and leadership. I think we would all, and I think the organizational folks here at Sloan would agree that there is a lot more to making this happen than just saying we're going to change the compensation program. So with that introduction, let me invite the panel to come down. Good, you're all here. I had alerted that maybe somebody was running late and I was going to have to sing and dance and otherwise entertain you until we were ready to start. So you can all breathe a sigh of relief that we don't have to do that. So let me start and introduce the panel. I'm really excited about having this group here, we have individuals who represent a range of different perspectives on the industry. Let me start to my immediate left, Eric Weil. Eric comes to us from MGH, where he's the Associate Chief for Clinical Affairs in the Division of General Medicine. He oversees the primary care clinical operations for a division of over 200 physicians, primary care physicians across 20 different practice sites. And I think one of the perspectives that Eric will bring to us is he serves as the medical director within the Population Health Management organization for the Partners Healthcare System. So thank you for agreeing to be here. Next to Eric is Dana Safran. Dr. Safran is the Chief Performance Measurement and Improvement Officer and Senior Vice President of Enterprise Analytics for Blue Cross Blue Shield of Massachusetts. She leads all of her organization's efforts to measure and improve healthcare quality, safety, and outcomes as a major payer for medical services here in the state. She is an advisor on quality measurement to a variety of organizations at the national and state level and has developed what are regarded as the accepted industry standards for measuring the patient care experience. So delighted to have you with us. Next is a client, a representative from one of my firm's clients, Rick Koehler, who comes to us from the Marshfield Clinic in Marshfield, Wisconsin. Thanks for making the trip to join us. Marshfield Clinic is a physician-led organization, a healthcare system serving northern, central, and western Wisconsin with over 50 clinic locations, 2 hospitals, more than 700 physicians in 80 different medical specialties. And Rick is a practicing internal medicine physician and is the chair of the clinic's Salary Advisory Committee, which means he probably has a lead shield that he keeps with him to deflect the criticisms about how and how much physicians are paid. He served as chair of the clinic's Department of Internal Medicine for almost 10 years and has been on the Salary Advisory Board for almost 10 years, chair of that organization for the last 3 years or so. And then finally, Dr. Daniel Allen. Dan is from another client of my firm's. He is the Chief Medical Officer of the UnityPoint Clinic. UnityPoint is, the clinic is part of UnityPoint Health Organization. UPH is the 13th largest not-for-profit health system in the U.S., providing care through 9 regional affiliates, 33 hospitals across a 3-state area. And Dan's responsibilities encompass oversight of the medical operations for a clinic with more than 1,200 physicians operating in over 280 clinical sites. So I think we have an interesting combination of individuals here. We have academic medicine, we have payer organization, we have a physician-based healthcare system, and we have more of a traditional community hospital-based health system. So I think it'll be interesting to see the different perspectives of the panel members here. There is some overlap. Rick's organization is also a teaching organization for, I believe, the University of Wisconsin School of Medicine. Both Rick and Dan represent organizations that have been active in the development and growth of accountable care organization, medical home services within their systems as well. So some interesting experiences there. I'd like to start off with Dana, if I may. As a representative of Blue Cross and an individual with some of the most extensive background I think I've encountered in working in the area of quality metrics. Dana, my startup question to you is, what do you believe are the most important issues that the providers you work with face in working to achieve better quality performance? And perhaps in line with that, what strategies have you seen organizations use that seem to be working effectively?
So that's a deep question, Joe.
Yeah, I put you on the hot spot right away, but you know, you had such a wonderful resume of great qualifications that I thought we'd just throw the challenge right out there at the very beginning.
So we'll go for it. And I know we have an audience that's mixed, some folks who are steeped in health and healthcare issues and other folks who are from other sectors. So I'll try to speak to the whole broad spectrum. So let me start with definition. When you ask about the greatest challenges in improving quality performance, we really have to ask ourselves, what do we mean by quality? And the field, at least in healthcare, has broken that into 3 different types of quality measures that we use as a framework, and that's served us well since it was invented several decades ago by a scholar, Avidus Donabedian. So he said we could measure quality through structure, process, and outcomes. And so I would say one of the greatest challenges is that today, and probably greatest sources of frustration for providers, is that today the vast majority of measures that we have and that we use, both we as payers and even in provider organizations, the measures being used for the most part deal in great detail with the process of care, clinical process. So what was done and was it the appropriate thing? And that is a mentality for measurement and an approach to measurement that in a lot of ways is very compatible with the old fee-for-service way of paying for care, right? So when you're paying by the unit, you want to make sure that the unit that's getting done is the right unit and getting done in the right way. But now, as Joe outlined for you at the beginning, there's an enormous shift underway to move from paying for volume or units of care under fee-for-service to paying for value or outcomes of care. And so I think one of our greatest challenges is that we are steeped in measures of process, and we have actually quite little in the way of measures of outcomes. And in particular, measures of the kind of outcomes that really reflect how a patient's health status and well-being has been improved or maintained or maybe even declined through the process of care. So what I mean there is usually referred to as patient-reported outcome measures or PROMs. And these are the things that, every one of us here on the panel and in the audience, if somebody asks you how you're doing, they're kind of the things you run through in your mind on how you're doing from a health perspective. It's your physical functioning, it's the amount of pain you're in, it's your emotional well-being. And these are things that really haven't been measured in healthcare. And as a result, we have very few tools to know how well what we're doing is working in a systematic way. I was on a panel about a year ago, and I'll just share this anecdote because I think it really paints it perfectly, with a physician from MD Anderson who was leading the implementation of patient-reported outcomes and shared a story of sitting with head and neck surgeons and saying to them, for your field, what is the most important outcome? And they all said, that's very easy. It's ability to speak and ability to swallow. And so he said, great, so how are you doing with that? And they said, we have no idea. And he said, okay, well, let's go to the medical records. And they said, it's not in there. And these are things really primarily you can only learn by actually asking the patient or assessing the patient in a specific way. So I think that paints the picture, and that's our greatest challenge. So as we make this shift, we're making it right now with measures that are primarily about the process of care. And as we try to now have a system that's encompassing the totality of care with global budgets, there's an enormous amount of process you would need to evaluate if you really want to know the quality of care for the whole of what's encompassed by global budgets. So the problem that many physicians are struggling under right now, of the weight of process measures, in a lot of ways could get worse if we don't accelerate the work that we're doing toward the adoption of very good outcome measures. At its simplest form, the outcome measures we need are three. We're trying to make the quality of care better, lower cost, better health outcomes. So we really need, three global indicators. On the cost side, we do have an Uber measure, right? Total cost of care, we can measure that. We don't have such an Uber measure for quality or the sort of clinical process, nor for health outcomes. But the work that I and others are involved in are going to get us as close as we can get to that, and that'll help us both to achieve the goal of knowing where we're going and being able to get there, but also relieving some of the burden from physicians. Say one last thing to address your last point. That means that we as payers won't have to sort of appear to be micromanaging what we're asking clinicians to do. You just set the bar and say, here's the outcome we're looking for, you invent how to get there. In my experience, that's what's worked the best, both from us as a payer to our providers, but also for providers creating incentives down the line to their frontline clinicians, is don't say how to get there. Say what the outcome is you're trying to achieve and let folks invent the solution.
Good, thank you. Dan, I saw you sort of nodding as agreement with the concept. Is there your own experience in moving towards outcome measures, if you could share that?
The yin and yang there is actually getting clinicians to engage in those metrics when they cannot connect it to the work they're doing. We heard both from workflow as well as really, is that really important to the outcome of the patient? And to hear the systems that we're involved in, either our own insurance products or those that we partner with as healthcare deliverers, actually say, here's the bar, we've agreed on it, it is relative, it is relevant, but you figure out how to get there, I think generates the type of creativity that actually gets clinicians re-engaged. So a head and neck surgeon's not too unhappy to say, I'd like to know I was doing a good job. I mean, that's why they do the work. So creating a platform from a data informatics standpoint that's dependable and believable, and then actually matching that to a real outcome is really the secret sauce of that, of moving to that last one, which you say improving the health of populations.
Rick, I'm interested in your perspective. I think many people feel that the healthcare systems that have grown from a traditional physician group practice space, yours, Geisinger, Mayo, some other notable names, may be somewhat ahead of the game because of the tradition of physician leadership in defining what value is, what you should be measuring. If you could share perhaps some of your experiences at Marshfield in that regard.
Sure, I'd be happy to, and thanks for having me here. Let me start by saying, and hearkening back to your initial slides, is that I think one of the largest impediments to really being successful with value-based care is the fee-for-service reimbursement system. We get paid for doing more of what we do, whether we do it well or not, to be quite frank. And so to change providers' mindsets and help them embrace a more value-based system, compensation has to evolve. As far as the clinic, I feel that, excuse me, I feel very fortunate to have been brought up and raised in the Marshfield system. It has a long history of significant investment in infrastructure, and we have an in-house electronic health record, and we'll be rolling out the third generation of that in 2017. And embedded in that EHR infrastructure is a number of portals. One we call the PRIDE portal, which is providing reports for informed decision environment, that has multiple dashboards: population health, meaningful use, key performance indicators, what we call group practice values, which is patient satisfaction, physician engagement, and our quality metrics, patient experience, and E&M coding profiles. I think what we suffer from is an overabundance of different indicators, and it's very difficult for a practicing physician to attend to all of these. And so as we were looking at how to change the medical record, for one, and compensation, which is kind of my wheelhouse, we want to focus on key quality indicators and key metrics that have the most beneficial impact on patient outcomes.
Eric, what's your perspective on where you stand in your organization in moving towards, identifying and moving towards more of a value or outcome-based performance measurement program?
What he said. No, just joking. I would say that in an ideal world, we would like to have form following function. Unfortunately, the way that things often work in practicality is that form follows finance. And the design of many of our primary care practices, as they have existed for many, many years, is in a fee-for-service sort of environment. And the staffing is structured around fee-for-service, and the teams are set up around fee-for-service. And the physicians approach the world from the point of view of fee-for-service. And yet, at the same time as that, the field of medicine and the way that we practice it has profoundly changed in the past decade. And so, harking to the panel that was just here, many of the things that panel was excited about, the things that they were talking about, those types of technologies aren't really built into the way we're expected to practice right now. And that creates a huge cognitive dissonance in the minds of the people who are actually providing care on the ground. And so we hear about the quality metrics and the ones that are the most meaningful. We hear about the direction that healthcare is moving in, and yet the structure and the incentives that are in place lag behind that by a very significant degree. And so it becomes the challenge of the leaders of our systems to help move that process along. And so we have to bring along the physicians who aren't comfortable with that change, and we have to modulate the wonderful ideas that are being laid out for us ahead of us to make sure that the distance between present and future state can kind of tighten up a little bit.
So now you have responsibility just within a group of primary care physicians, which
Right.
I would think might give you a more defined framework to work within, because you don't have to deal with the diversity of specialties and a lot of the procedural-based practices that may be present in a diversified organization or a multi-specialty group. Has that allowed you to take any steps, try any initiatives just within the primary care group that you're finding to be effective?
Well, absolutely. We have been actively involved in a wide variety of population health management strategies for the past decade, which include embedding practice-based care managers into all of our sites, going through medical home transformation. We have strategies in place for behavioral health integration, for long-term continuity of care. I'd like to point out, however, that even within primary care, there is a huge heterogeneity in terms of providers and of patients. And so you can have a primary care practice out in the suburbs that has a very healthy population, and you can have a primary care practice at a community health center that has 50% of their patients not speaking English, right? A large number of patients who are underinsured or uninsured. And so some of the challenge in the system is to figure out how you can develop tools that are applicable to these different environments.
And the idea of scorecards, I know, Rick, you mentioned having a scorecard. Can you perhaps talk a little bit more about some of the specifics and maybe how you developed the scorecard and how you're using that within the clinic organization?
Sure. There's a number of various databases or dashboards within our electronic health system that one can go to. So I can pull up my population health management and look at various target graphs of how I'm doing with the various subcategories of different disease states. But I can look at immunization rates and my patient satisfaction. But these are all sort of in different areas within the PRIDE portal, and I think, to be honest, the PRIDE portal's been underutilized simply because of the time constraints of practice amongst our providers. And it takes a little bit of interest to get in there and dig around and find the data. And so what we've done as part of our comp plan redesign process, and I'll say that we started with primary care because we believe that a healthy primary care base is required for a healthy clinic. Part of that process was putting the, if I'm a practicing physician, yes, I try to do a good job. I try to satisfy my patients and provide quality care. But at the end of the day, I only have so much time. And so, we want to put everything in one place so that what's important, for example, in my corner of the world, compensation, how am I doing with respect to the various measures that are going to affect my compensation? And so that's the scorecard that we've developed, and the providers get that quarterly. The information on our databases are updated within a day after the information is updated. But hopefully by doing this, it'll encourage providers to be a bit more engaged and provide them more information about what they need to do to change. I don't know how much you want to go into what we've done with primary care compensation, but a traditional RVU-based comp model does not encourage providers to move from the individual craftsman to a team sport, which is what we need to do today because there's too much going on for me as an individual provider to attend to in the course of a 20-minute office visit. And therefore, we've put mechanisms in place that move a lot of that off of my plate and onto my staff's plate. And I can say this because I'm a physician, but if you want something done reliably, have the staff do it. Because in the context of a busy office visit, it's very hard to keep all of those things in the front of your mind. And so we've got systems in place and workflows in place that encourage the staff to collect a lot of this data and check a lot of the boxes that we have to check to be an ACO and maintain our meaningful use status and whatnot. As far as compensation is concerned, for about the last 5 years, we've had 10% of compensation based on what we call group practice values, a third of it on patient satisfaction using Press Ganey, a third of it based on various quality initiatives, developing outcome measures, one global hypertension control improvement throughout the clinic system, and others. And then the other third is based on what we call citizenship, which is primarily physician engagement. You can't engage physicians and get them involved in the changes that need to happen at the ever-increasing rate if they're not showing up to department meetings, service line meetings, or our Class A member meetings. And therefore, we weren't above coercion to get them engaged, and it's been very successful. Going forward, what we've done to increase the emphasis on value within our comp plan, as we have increased the value-based comp, will be 15% for primary care. Of that, 5% will still be citizenship, and enrolled in the citizenship will be participation and quality metrics, and 10% will be based on what we call efficiency. And so for primary care, 5% will be based on your WIO, or Wisconsin Health Information Organization data on total resource use and 5% on WIO data for referrals. In addition to that, we're moving and backing away from the almighty RVU, and so starting in 18, the primary care physicians, half of their production is going to be measured by their patient panel rather than RVU. We didn't think it was prudent to move completely away from RVU since about half our business is still fee-for-service, and we still have to have people filling out their chart sheets.
Yeah, good, thanks. You had a comment or?
Oh, I was just going to say, I'd like to talk to you after this. We're in the process of having active discussions about a model that's very similar to that. I think points that are worth emphasizing are that physicians aren't trained as a part of their medical school and residency training to look at this type of data. And it's not something that many are comfortable with. And quite frankly, often the leaders of these practices are also not particularly skilled in understanding how to interpret this information and offer that feedback to their clinicians. And so an important piece of this strategy is making sure that the physicians understand what they're looking at and why, and that the leaders of these practices are also trained in taking that information and processing it and making sure that it's understood. And so I imagine that's something that you have all thought about, and it's something that as you design a system, the leadership training and the training to the clinicians can't be overemphasized.
Yeah,
Comment on that, Joe?
yes, please.
Yeah, I think that's really, really important point that Eric's made. And one of the things that Blue Cross of Massachusetts has done in order to have our global budget model be as successful as it has and adopted as broadly is to put in place what we've called an AQC support model. So, and what that means is we work in partnership with the provider organizations that come into this global budget contract with an enormous amount of data and best practice sharing and consultative support. Part of what has been built into that, I think the two pieces really relevant to what Eric said that I would share is, number one, that we share an enormous amount of data on what we call practice pattern variation analysis. So taking an episode of care, looking to see if physicians in our network differ when they take care of patients for an episode like that in what they spend. If they do, then finding what the one or two big drivers of that is, and showing in graphic terms to physicians and the provider organizations where they fall on that spectrum of tendency to do that thing. And what's amazing is for every type of episode we look at, hypertension, reflux, any disease you look at in any specialty, we find that there's one main driver of the differences in cost, and that physicians' tendency to use that thing ranges from 0 to 100. Even when they practice in the same hallway as each other, they span the whole curve. But they had no idea until they started to see this data, right? So part of what's valuable about the fact that we have shared risk contracts now is we don't have to come in as the health plan saying, we know the right number and we're going to manage you to it. We say, you have a budget to manage and this can't all be right, but you're the doctors. So you look at the data and figure out what you think is best practice, and we'll keep showing you the data on how you're doing and sort of narrowing that variation. And that's where the leadership part that Eric mentioned also comes in, because physician leaders under fee-for-service models were not trained to work with their practice and have conversations like that. It was, in fact, I think, my colleagues here would agree, pretty taboo to interfere or even, ask questions about somebody else's clinical decision-making. It was quite uncomfortable. And so one of the things we've done is, working with the American College of Physician Executives, develop a 9-month leadership training course to help physician leaders understand, this new job, including how to have conversations like the ones Eric's talking about.
Excellent.
Yeah.
Dan, tell us a little bit about your journey, where you are on the journey from maybe a tradition of fee-for-service, which I'm going to assume is part of the background, to more of a value-based environment. where are you in the spectrum, and what are some of the steps you've taken to move your group along?
So I'm basically being paid on commission as well. I think that was, and have been paid on commission for years. So we've gone to an RVU model for compensation for years. The value of that is it does allow you to kind of adjust your RVU value and then use some of the monies that you get when you provide care in this big bucket of money, so you can actually be creative in your comp models versus the old revenue minus expenses mouse wheel that you did when you were fee for service. So we've been doing performance incentive for a number of years. I think the most important transition is probably the last 3 to 5. And we've gradually increased our incentive percent just recently to 14 for primary care, 14%. We actually have a specialty performance incentive, and they have a core set of quality metrics, which creates a lot of dialogue because our specialists don't necessarily think they should manage blood pressure or smoking cessation. Conceptually, that's difficult. They have less measures, and the translation of that story is that, and I'll back into this later, when you talk about shared savings, which is one of the models we're using for revenue and compensation these days, if a specialist moves even a small number of patients that haven't seen their primary care doc into that primary care space so we can actually intervene, that translates to real money. So it means a lot as far as the greater goal. So the really burning platform is before we as a practice in UnityPoint Clinic could basically adjust our yearly budgets to whatever rate increase we had from the payers, and we just adjust our contacts, see more people, generate more revenue. Well, as we've already decided, and I think no one would disagree, we didn't necessarily provide great care all the time, and hence our current environment. So we are now dealing with this shared savings model, which is the interim between value-based contracting, which is not capitation necessarily, it's a spectrum, and that shared savings is now being put in a bucket that's at risk for our group. So when we don't get as much increase in rates and we have this money that we have to perform to get, it gets our attention. And that's what's driven our comp changes. Now the good news is the story there is really about, it really does translate to better outcomes. We're getting to the point where we'll hopefully have data to show that. And some of the things that we use for metrics really don't have an impact for 5 to 10 years. So some of these patients that we actually apply these metrics to, we won't see the change until later. So we've increased our performance incentive. We've built some workflow aids, if you will, and I'd call patient-centered medical home a workflow aid. Mm-hmm. Great way to deliver care, great way to actually have someone else do the metrics besides physicians or advanced practitioners. Our huddles, our care coordinators within that space help manage those metrics so that we can actually perform as a clinic. The place we're going to is really probably not one comp plan for all. I mean, we have comp philosophy, but primary care is going to be in this non-RVU based. We'll have a productivity piece that's probably about a third. We'll have a third in panel size. If we can figure out how the EHR can attribute it correctly, it would help. We'll also do a risk adjustment because, to the point Eric mentioned, not all practices are the same. Some people are sicker, some are more healthy. And then we'll have a third that'll be at risk for performance incentive. And we also have various percents on whether that's quality, finance, or patient experience. And those have to line up with all the external measures we have. So CMS has one, payers have one, star ratings impact all that. So that's going to be a moving target. The specialists, on the other hand, we may have to look at differently because in a value-based contract that's capitated, we may want them doing lots of procedures. It doesn't make any sense to incentivize a specialist if you need them to do procedures to be good in that contract. Some specialists, we may have to say, you know what, we'll pay you not to do the procedure, but pick up the phone and call the primary care physician and say, why not? So I think it's that kind of journey we're on. I predict we'll be, like you, probably to a really value-based comp plan, not RVU-based totally. Probably in 18 months to 2 years. I think if we wait much longer, I think the tipping point from the at-risk contracts will be too late, because it is a balancing act between that fee for service, which we'll all continue to get some percent, but we could have upwards, our CEO is predicting 30 to 40% of our revenue will be at risk, which is pretty big.
To throw you a bit of a curveball here, one of the things I've experienced in a lot of the organizations I work with is difficulty getting the physicians to accept some, or in some cases any, of these measures as measures that they are truly accountable for. I've often joked when I'm done with this, I'm going to write a book about all the excuses I've heard of why clients, physicians can't be accountable for various performance. Have any of you, well, you probably all encountered it, so the question would be, in encountering that, are there tactics that you have used to try to gain more buy-in and more acceptance that these are important measures and they are things that the physicians need to accept accountability for? I'll let anyone who wants to kick in with that.
We'll all have a perspective in our battle scars, I'm certain of that.
I guess this, our kind of upping the ante with the value-based basis of our primary care compensation plan is relatively new. We rolled this out just before the end of September to providers because the measurement period for salary year 18 started October 1st with our fiscal year. And one thing that the administration of the clinic has learned is, you have to do things stepwise. So as part of the development of this comp plan, we engaged key primary care physicians within the discussion as we were developing it. We vetted this with systems operations and our board. And during the month of September, I kind of took my show on the road and visited multiple different sites and met with primary care providers, talked to them about what it means and why we're doing it, and lived to tell the tale. And I think part of why this was met, I mean, there are obviously some providers who had some concerns after they saw their scorecards of where they would potentially wind up. Small panels, high RVUs, things that are going to be deadly to us in a capitated world. But I think what helped us is the understanding, at least from primary care providers, is if you want to be creative in how you provide care to patients, you can't pay physicians for everything they do, because why would I want to have that patient come back and see my nurse or nurse practitioner for their hypertensive follow-up because it's going to cost me RVUs, or why call somebody on the phone when it potentially can generate an office visit. So I think moving away from the RVUs encourages more of a mindset for team care. It certainly got people discussing how they can work their patients in and improve their continuity, because if you're going to pay based on panel, you have to have rather robust continuity measures to avoid gaming. And the other thing that panel-based payment recognizes is the increasing volume of indirect work that faces providers. That, the providers are always grousing about all the time they spend with phone calls and DME scripts and prior auths, and so at least now they understand that there's some recognition for that part of the care process as well. And then before I be quiet here, and our goal is in 19 to roll out a plan for specialty care, which uses caseload as a metric to replace some of the RVU metrics.
So I was going to say that when I meet with clinicians to talk about this, I always say that my secret agenda is to actually improve care for patients. And that actually resonates with people, that if we do this sort of work the right way, we're actually hopefully improving the quality of the care that we deliver. And so that it appeals to the message, it's the right thing to do. And most of the physicians went into the business because they want to help people. So we have to be able to make that argument, and if you can't make that connection, then there's a problem. And so, first principle is this the right thing to do? Does it improve care? And if you can get people to nod their heads to that, it's a pretty good start. The second rule is it should be able to improve the quality of your life, right? It should improve the work in the office. It should make it so that you're doing the things that actually brought you to work. The message is you should go home at the end of the day tired but happy. It's okay to work hard, but you have to be able to say that the models that are in place make sense for you. And then the third piece is you have to be able to engage the physicians who are going to be the recipients of this change, and arguably the patients as well, but in this case it's a redesign on the physician level, to be involved in making the decisions that are going to impact upon their future. And so if you can line those things up the right way, it makes a difficult conversation at least a little bit easier.
I'd just add one observation, and that is that one of the best ways I've seen to have physicians take accountability for performance measures is to show them the results but not ask them to be accountable. And I'll tell you the reason I say that. So easiest to illustrate with a quick story. So in work I did before Blue Cross, working with a provider organization that was trying very hard to improve patient experience of care because they found that they were losing market share. They were having a lot of churn. Patients would come and stay, but they wouldn't stay. And when they surveyed their patients, the patients didn't express feeling any real connection to anyone in the practice. So they were trying to really enhance that. And that was at the time the work I was doing. So I worked with them on a measurement program where they were measuring at the individual physician level and feeding that data back. But the organization was saying, we're going to give you your data every quarter on what your patients are experiencing with you, but we're going to be changing things centrally and in the system so that everybody's scores are going to get better and you don't have to worry, you don't have to try to do anything differently. And so they did that, and within about 9 months, physicians went from really questioning the data that they were seeing about themselves and thinking, this can't be right. My patients are more difficult. My patients are grumpy. These measures don't really measure anything. And what they started to see quarter by quarter is that their scores, their own individual scores, really looked the same, particularly relative to their peers. So they started to believe the data. And the organization was improving, and so everyone's scores were kind of moving, but relative to their peers, they were kind of still performing right as they had been. And so by the time the organization got ready to say, okay, now we're going to do a communication skills building program, they had physician uptake selling out the program twice in 2 minutes over email. Because physicians were so hungry at that point to actually figure out what they could do to improve their own performance.
Wonderful, thanks. Let's take some time for questions from the audience. I have several more if the audience doesn't, but...
Yeah, the microphone right here.
Okay.
Oh, thanks. A little bit of a hypothetical question for you. Assume that that you have some sort of a closed form, a closed system, where all the physicians and all the specialists are all in one group, and all the patients stay there the whole year. And each physician is normalized in terms of their efficiency and their productivity. And I'm sort of getting at the question of, if you guys could put in place a system that had all the measurements you wanted, and it captured all the data you can think of that's appropriate, how good are we today in this outcome assessment measurement system? How much would you then think would be fair to put on the physicians as an outcome assessment correlation to their salary? What percentage of their work do you think we can now account for with the assessment models you have, assuming all the other givens?
I'm looking at you.
You're looking at me.
Everybody's looking at each other.
Yeah, I think I'm looking at the ceiling going, don't look at me.
So, go ahead, Eric.
Well, it's a hypothetical question and a difficult one to prove. I would say you'll never be able to put 100% on physicians, right? There are many social determinants of health that play into healthcare outcomes that our current healthcare systems don't have the capacity to manage, right? And so at baseline, there's a huge variation that comes into play just because of that. That being said, I can think of a healthcare system in Alaska, which really is the only gig in town, right? Literally. And they have many more, and they interface with the city and state governments in a way that's far more advanced than anything that we do in New England. And they do have a lot more control, and they are able to see much more outcome based on the actual work that they're doing. And so I would say that if you were in fact living in a terrarium and you were able to do this, you would be able to more comfortably put a considerably higher level of outcomes onto physicians. Now, how much that is, we're not there, so it's hard to say.
You don't have a hunch as to whether it would be over 50%, would be a fair thing. Are we that good with our assessment models, assuming we could
Which outcomes?
implement them?
Right? I mean, if you're talking about diabetic outcomes, that may be one thing. If you're talking about opioid overdoses, it's another, right? And so I think it really is something that you need to think about on the individual outcome basis. Patient-reported outcomes, if it's a back surgery, that may be one thing. If it's patient-reported outcomes in another way, it may be lower.
Yeah, it's a wonderful question, and I wish it was a simple one to answer, but it's so complex to answer. Among other things, there are many things that we can measure and measure very well that we could almost never measure at the individual physician level because there wouldn't be enough sample to have stable, reliable estimates, or at least you wouldn't want to pay based on it or do anything else that's high stakes. There are other things that we can measure very precisely for individual physicians, but it's not really the important stuff. So yes, I think we probably could measure over half of what physicians do in a reliable and accurate way. But I'm still not sure that tells me that I would base 50% of their pay on how they're doing on those things. It's a really excellent question.
Over here. Go ahead.
Another question for the whole panel. So depending on which source you read, physician comp is anywhere from 8 to 9% up to 20% of healthcare expenditures in the country. So a decent chunk, right? And so we're doing all this work now collectively as an industry, moving around buckets, realigning incentives, but we can't have a zero-sum game. It's not a zero-sum game, right? We have to bend the cost curve on healthcare. We have to reduce healthcare expenditures. So a simple question is, do we have to overall, in aggregate, pay docs less than what we're paying them now? And I promise I won't tweet out the answer that you guys get.
So
Which physician wants to answer?
I'll jump in. As the non-physician on the panel, I'll jump in and say, one of the Uwe Reinhardt, who is one of the most brilliant health economists in the world, wrote an article not too long ago that said, "It's the price, stupid," talking about U.S. healthcare spending. Right. So we spend more than any other nation in the world. Our health outcomes are at the bottom third in economically developed nations. So we're not getting good value. And we work so hard as a system on getting to the right amount and type of care. We're on the use lever. And that's because no one really feels that we can touch the price lever. But his point is that every part of our system, from physician comp all the way to everything else that we pay money for, we are paying far higher prices than any other nation on the planet. And so, yeah, we could make an important difference in our overall healthcare spending by addressing price. But I think that's proven to be a pretty hard lever to address. And so we lean on the other half of what drives trend, because price is about half of what drives trend. The other half is use.
Anyone else?
The only thing I would, this is a tricky question now, isn't it? But what I would say is that
you are being recorded.
You should just keep in mind that physician compensation and physician salaries are one piece of the puzzle, but there are many, many other pieces that need to be addressed at the same time as that. You know, how much of the total cost of care is pharmaceutical, right? It's
17%.
Yeah, it's ginormous, right? And so it may very well be that physician compensation needs to be addressed, but if it were addressed in a vacuum from all of the other parts that are also driving this problem, that would be unfair. And quite frankly, if some of the resources were allocated much farther upstream, let's say, focusing on the social determinants in our communities, we could probably make a profound difference in terms of the savings and improvement in health just by doing that.
I would agree. I think if you really want to bend the cost curve of healthcare, you've got to engage the patients on the front end and really reinforce healthy lifestyles. I do see a downward pressure in some specialties in compensation, but in others, they're like athletic free agents. I mean, they're in scarce supply, and if you want that service, you kind of have to pay market rates. So it's a difficult balancing act that we have to do. I know at least at Marshfield, we're taking a very hard look at our fees and are actually going to be lowering fees globally and individually this year as an attempt to reduce the cost of care within our system.
I would only add one more perspective, and I agree with everything that's been said, is that we focus on physicians as the key person in that delivery model, and it really will become a multifaceted delivery model. So that compensation impact, although it may flatten, I think the efficiency will be gained in actually thinking of different ways to deliver the care, which
Yes.
actually impacts the cost.
Yep.
The social determinants of healthcare is another whole facet. I mean, we can get the high risk, high cost stuff out pretty easy. That's just form and function. It's the changing the environment, engaging the patient that actually really affects long-term health.
I think that this has been one of the more insightful panels. All up here wrestling with a sensitive issue, especially the physicians. Not that it was easy for Dana, but especially the physicians. And Joe, thank you for assembling an interesting group. Thank you all.
Thank you.